Hi, this is Marty McCafferty with the medical department at DAN. As most of you know, we spend a lot of our time talking to divers, and unfortunately some injured divers over the course of the year. There's always a concern that when someone surfaces from a dive with symptoms, the automatic thinking is that they should get from their dive site, which is point A, to a chamber, which is point B, as soon as possible. There's not always that straight line, and it's for very good reason. So we need to talk about how physicians go about diagnosing decompression sickness and how we can better recognize it in the field. What makes it difficult and the challenges that we face with trying to diagnose decompression sickness, which by the way, we don't do at DAN over the phone. This is something only a physician can do in person. But trying to diagnose decompression sickness is a challenge because one, it is statistically rare. There are few doctors that have any real experience with it or frequent experience with it, so it can be difficult. The usual laboratory or imaging studies that do a wonderful job of diagnosing other illnesses or injuries can't confirm decompression illness as the diagnosis. They have to rely on a lot of other information. There is available data that can assist physicians in making that diagnosis, and most importantly, it provides a context for the symptom presentation so they understand what's going on and what to look for. So what information do we need to pass on and what's most important for us to gather? And that's what we're going to talk about today. And what's absolutely essential for divers to understand is that DCI is often a diagnosis by exclusion. You have to find out everything that it isn't before you can be sure of what it is. Imaging studies are most useful when it comes to ruling out other causes, such as X-rays, CAT scans, MRI, even ultrasound. Those things are best suited to ruling out other causes for the symptoms. You'll read that some blood samples may help increase the chance of diagnosing decompression sickness, but that's simply not viable. There are things that can help, but certainly you can't hang your hat on it, so to speak. An ultrasound or Doppler, we get asked a lot by divers if a hospital has that. When it comes to diagnosing decompression illness, the Doppler bubble detectors, the ultrasound are of no value with that. The treatment is not based on the amount of bubble counts that the divers have, but it's based on what their symptoms are. You can have low bubble counts and still have symptoms and vice versa. High bubble counts, no symptoms. So again, it's based on what the symptoms are that the diver has, not on the ultrasound bubble counts. When you look on the internet and in any textbooks, what you see is a list like this. And if you spend any time looking at the list, you should realize, and it should be fairly obvious, that the signs and symptoms of both decompression sickness and arterial gas embolism are not exclusive. There are many other illnesses, injuries, diseases that create these same signs and symptoms. So it's important to remember that when you find these lists, you can't use it as a checklist. It has to be the whole context of what's going on, not just a list. The pertinent information that we need to know, what makes it most important, are the symptom onset time relative to the diving. How long after the dive did the symptoms start? That's absolutely essential information to know. Other important information is the dive profile itself. What were the depths and bottom times? Those are key to their exposure. And also, what is the patient's medical history, including all their medications? Because it can be hard sometimes to distinguish between medication side effects and something that may be going on as a result of a dive injury. We also want to identify what the signs and symptoms are. What did they present with? And there are differences that can help differentiate between the character of the signs and symptoms associated with decompression sickness that are unique and different to some other things. And you also have to keep in mind what the context is. How did it show up, when, and all the information surrounding it. Let's take a look at a case example. We have a woman who is 58. She was a guest on liveaboard, and she began to complain of left shoulder pain after a dive. You can see her profile was relatively provocative. It certainly could create symptoms, and she had done 3 dives the day before. The staff was calling DAN, and their question to us was, should they provide O2 or transport the patient to the nearest chamber? Of course, there was more information that we needed to know. So our next question was, of course, how long after the dive did the pain start? And they told us, about 90 minutes, just after she fell against the bulkhead of the liveaboard. Her husband and others saw it because a wave had struck the boat. She lost her balance, so they knew exactly what happened. Our next question was, of course, were there any other symptoms? And they said yes, she had a very large bruised area on her upper arm. So even though it seems obvious, this is the kind of tunnel vision that people can develop. Certainly if you look at that list, left shoulder pain or any type of joint pain can be indicative of decompression sickness. But you have to look at the whole picture, the whole context. But divers do tend to get that tunnel vision where they miss the whole picture. Sometimes you can't see the forest for the trees. What we do at DAN Medicine, as most of you know, is we collect information from multiple sources. Certainly when you call us, that information is recorded. Please understand that we're subject to the same confidentiality rules and laws that any other healthcare provider is. But we get that information from divers, from their dive buddies, and we also share data with the international DANs, as well as the military and commercial diving. All that information gets into a database for statistical analysis. None of our researchers see any of the identifiers. So the questions we asked are based on the accumulation of data and experience over many years. We've been doing this for over 30 years. Those of us in DAN Medicine, we have a section that we mark what our clinical impression is. This is not by any means a diagnosis, but what we think may be going on with the patient. In 2009, we had an independent audit done by a PhD candidate who went through all of the cases that we had reviewed. What they found was that 70% of all the cases that we marked as a clinical impression of decompression sickness indeed were ultimately diagnosed as decompression sickness. And it's not that those of us in DAN Medicine are particularly smart people. It has to do with knowing what questions to ask and how to go through the process of getting the information. That is what goes on. And that questions and the questions we ask, the information we ask for, that keeps evolving as we learn more. Now the other 30% of the divers who were ultimately not diagnosed with decompression sickness, that wasn't because we weren't kind of asleep at the switch on that one. It should be a testament to the fact that there is no substitute for a direct evaluation by a physician. That's why they ended up not being decompression sickness, because they could get that kind of evaluation. When the subject of treating divers immediately after a dive comes up, there are those that will, of course, automatically say that in the military and commercial diving world, there's no process involved. They're immediately put into the chamber, which is very true, and that's fitting for that environment. The health and fitness requirements for commercial divers is far more stricter than those for recreational divers because the job demands that kind of fitness and health. So the requirements are very different. People that can dive recreationally would probably not qualify as a commercial or military diver. Also, with the commercial divers, certainly military, they have to go through a periodic reevaluation of their health and fitness. Certainly if they have any kind of an injury that's not even dive related, they need to be reevaluated and released for work by a physician. With sport divers, this is not required. There's only in certain circumstances that divers are asked to have a new dive physical. There are many divers we talk to that started diving 20, 30 years ago that may have had an exam initially, but the way their diving has progressed, they've never had to have another dive physical per se. So that's another factor that comes into play with recreational divers. So the bottom line to commercial and military divers is that if they surface with symptoms from a dive, there are far fewer potential causes for symptoms among this group than there are among recreational divers, because recreational divers have a much broader medical history, and there is more likely that it could be something other than decompression sickness. So we get back to that symptom onset time. I can't emphasize this enough because it's absolutely essential to figuring out what's going on. An arterial gas embolism is something that occurs within the first 15 minutes after surfacing. It does not happen hours down the line. And it isn't just a matter of statistics. There are factors of physics and physiology that explain that short onset time, and we'll talk more about that. The more severe the symptoms of decompression sickness are, the quicker the onset. Serious decompression sickness shows up within the first 1 to 4 hours. So the more injured the diver is, the quicker the symptoms show up. So there's usually not a huge delay with someone who's seriously injured. 80% of all decompression sickness cases present within the first 12 hours. Symptoms can present as long as 24 to 36 hours after diving. Seldom is it longer than 24 hours. Now, you may read on the internet or other sources that divers can develop symptoms of decompression sickness 3, 5, even 7 days out from their last dive. You really need to think about that statement. You all understand that we're considered safe to fly within 18 to 24 hours after the last dive. If we really could develop symptoms longer than that, we would all be waiting significantly longer after diving before we fly. So anytime you hear that statement, please think about it in that context. Let's take a look at the statistical data, and just to make a quick point where it says missing, that's just the dive information is missing, the diver wasn't. And it should be to no one's surprise that the serious symptoms like arterial gas embolism, the AGE, type 2, which is neurological DCS, and even type 1, which is pain, show up within the first hour, and then it tapers off accordingly. What should be a little disturbing to some of you is that there were symptoms reported prior to the last dive. Now, that means that the divers didn't recognize the possibility that something was wrong and they continued to dive. But again, most of the symptoms show up very quickly after the dive. So you want to get a good history on their dives. What was their exposure and their potential decompression stress? Again, the dive profiles and their gas mix. These are essential. What was the time and depth? Also, were they working hard at depth? Were they exerting themselves, swimming against a tough current? Were they working, performing tasks? Their thermal stress, whether or not they had adequate protection, that's mostly a subjective. There's no way to really objectively determine that. But again, you need to know the number of dives in the series, and certainly what was the surface interval between sequential dives. That can play a huge part in how likely they are to have symptoms. This refers to what's known as an index of suspicion. So the higher the index of suspicion, the more likely decompression sickness might be. But there are things to help raise and lower that index. When you have patients or divers like me that are baby boomers that bring our medical history with us when we're diving, an important question to ask them is, are their current symptoms different than what they've experienced before? Consistently, we talk to divers that have existing problems, and they report that the symptoms they're experiencing with decompression sickness are different than what they've experienced before. So that's important information to know. What are their chronic health conditions or any previous injury to the same area that they're complaining about? Did they have previous surgeries? And are they on any medications, whether it's over-the-counter or prescription? And have they just recently started taking it, or have they been on it a long time? One medicine that comes to mind as far as side effects go, the statin medicines that are used to control cholesterol. These are all very good medicines, very commonly prescribed. But if you remember, far down in the list of possible side effects, you hear that the individual may experience unexplained muscle pain or weakness, which sounds a lot like decompression sickness. So knowing what medications they're on can certainly help a physician decide whether this is a medication side effect or whether there's really something else going on. And were there any recent changes in their health history? Are they just recovering from an illness? Have they been dealing with motion sickness? Was there any recent trauma? Much like our lady that fell on the liveaboard. That's a recent trauma. Something that simple can help the doctors have precise and better information to make a decision from. Let's take a look at the chronic health problems that divers tend to bring with them. These are divers that participated in DAN's Project Dive exploration. None of these divers were injured, but this is what they report as their chronic health problems. And you can see the primary ones are allergies, high blood pressure, and ear and sinus issues. Everything else is in a much lower percentage below that. So generally, recreational divers are fairly healthy, but we do bring our problems with us. So when we talk about musculoskeletal complaints, joint and muscle pain, which is one of the first things you read about when it comes to decompression sickness, what's an important distinction is that it's not unusual for pain in a joint to increase and then slightly decrease, kind of come in waves, kind of grow in intensity, then die down. That's normal. That's expected. What is not typical of decompression sickness is that the pain goes away completely, comes back later. Decompression sickness doesn't tend to come and go. So that's an important distinction. If it goes away completely, comes back later, that should reduce that index of suspicion. Also, symptoms don't randomly migrate. They won't jump from one joint to another. You won't have shoulder pain, then knee pain, then ankle pain, then back up to the other shoulder. It just doesn't work like that. Generally, the pain in a joint or the muscles is not affected by position or exertion. It's like the old joke, doctor, it hurts when I do this. Well, don't do that. If it's specific to a motion, then it's probably not decompression sickness. Usually we hear divers saying that they can't find a comfortable position and nothing seems to affect it. The quality of pain associated with decompression illness is different than other pains. If you look at the words on the screen, it talks about it being deep, boring, or throbbing. You'll notice that sharp or stabbing is missing. Now that doesn't mean that it can't be sharp or stabbing, but the words you see used to describe it are what divers typically use. So deep, boring, or throbbing. Now I have a shoulder that bothers me when I've done a lot of activity, and I know how much that shoulder should bother me depending on what I was doing. This is another key. If the shoulder pain or other joint pain or muscle pain is out of proportion to what the diver was actually doing, that too can suggest that there may be something else wrong. The paresthesia, which is that subjective tingling, burning, pricking, etc. numbness. The way divers describe it to us is it feels as though the limb fell asleep. If you've ever fallen asleep on your arm, you know what that feels like when you wake up and you really can't feel your arm. Also, they describe the tingling as that pins and needles. When your arm starts to have the circulation returned and you get that pins and needles, that's also what they describe it as. And it too is usually constant. It does not come and go. We'll talk to divers that have this fleeting tingling here or there, but again, symptoms associated with decompression sickness, once they start, they usually remain constant. And the paresthesias are the most commonly reported symptom. That's what we hear most often. It can be unilateral or bilateral, which means it can be in one side or both sides. And it can be accompanied by muscular weakness. So if you've got someone that's complaining of paresthesia, that numbness, tingling, look to make sure whether it's one side or both, and also check their strength, because that's going to be important information. With the muscular weakness, you have to consider other causes. Is this, again, a medication side effect, as that can often happen? Also, did they have surgery or a previous injury to that arm? So maybe that one arm being weaker than the other, or that one leg being weaker than the other, that may be normal for them. So it's important to know what their medical history is and decide, is this something new or is this something that's already been in place? The weakness can be difficulty walking, and that's going to be kind of hard to distinguish because sometimes balance problems can present as difficulty walking. But are they having trouble standing up? Can they support their own weight on their legs? And are they able to sit up? Do they have enough trunk strength to hold themselves in a seated position? That's important information to know. And that decreased leg strength, with legs, it's usually both legs. Bilateral means both sides. When there's weakness in the arms, it's usually one-sided, not both-sided. Now, it doesn't mean that it can't be weakness in both arms, it's just not typical. But keep in mind and measure the strength and really check that out, because that can raise or lower your index of suspicion. One of the other aspects of decompression sickness that can be kind of confusing are the skin symptoms. You read that they could have a rash. Well, it's not a typical rash. It's different than what you normally see. The skin manifestations, and this is the medical term for it, is cutis marmorata. If you look at the photograph, you can see it's blotchy or marbled. And that's typically what we see with skin symptoms associated with decompression sickness. Now, if you look at the picture on the right, this is that normal, what we call urticaria or the hives. You see how it's more red and it's raised, whereas the symptoms with decompression sickness tends to be flat and more purple or bruised looking. In 10 to 15% of all DCI cases, we do see these skin symptoms. But remember, if it looks like a regular rash, it probably is. If it looks different than a normal rash, be suspicious of other symptoms. So along with that cutis marmorata, the biggest complaint is deep tissue soreness, especially divers that get it around the abdomen. They say it feels like they did way too many sit-ups. The itching is a secondary complaint, it's not the primary. Usually it's that deep tissue soreness that's the primary complaint. And it's most often in areas where we all carry that extra layer of fatty tissue. Regardless of how good a shape you're in, that's always there. Typically abdomen, thighs, buttocks, and around the love handle area. It can also affect the chest or the triceps, and ladies will sometimes come up complaining of pain in one or both breasts. So that's another distinction. 20% of all the divers that present with just skin symptoms, 20% of those folks do have some kind of neurological symptoms. It can be visual disturbances or mental status changes, being confused or having short-term memory problems. One case we were involved in, a woman had been on a dive trip with her friends. They were now eating lunch, and suddenly she couldn't remember where they were or where they were diving. She couldn't recall any of the dives that morning. She had the skin symptoms, but she also suddenly couldn't remember where she was. We'll look again at some statistics. If you look at the green bars, that's the first symptom. What shows up first? And you'll see that pain shows up first over all other symptoms. So pain usually is the first symptom, followed by that paresthesia, numbness, and tingling. And you can see that the paresthesia is the greatest reported symptom over all the others. Fortunately, the more serious symptoms you can see appear in much smaller numbers. So pain and paresthesia are always going to be the presenting and primary complaints. We talked about arterial gas embolism and why it happens so quickly after a dive. Let's take a look at the mechanics of it. If you come up from a dive and you're holding your breath, it actually causes the small air sacs, the alveoli, to rupture, which immediately forces gas into the arterial circulation, which is carried to the left side of the heart, and then it goes into the aorta, which is the largest blood vessel in the body, and it gets distributed usually right to the brain. Now, how long do you think this is likely going to take to happen? Of course, it happens very quickly. This is why when we talk to divers who made a rapid ascent some 4 or 5 hours earlier and they have no symptoms, they don't have to be worried at this point for an arterial gas embolism. This happens within minutes. If you look at the dark area around the one lung, that's showing the area where the lung is collapsed. That's air filling the chest. And that is another reason why you don't want to take a diver and put them directly into the chamber. If that pneumothorax, which is the collapsed lung, is not addressed before you put them in the chamber, treating them can actually make that a lot worse. So a thorough evaluation is what's absolutely important. Now, I realize that I'm giving you a list, but this is important. These are the really serious symptoms that should immediately get your attention. And we know it's serious because it's affecting the central nervous system, be it the brain or the spinal cord. You look at these things. Hemiparesis means they're paralyzed on one side. That's very disturbing. Same thing with problems with walking. Pain in the lower back that radiates around to the front, that's known as girdle pain. Very problematic and should raise that index of suspicion. Certainly the cognitive deficits, which we'll talk a little more about, and acute fatigue. That's another one of those aspects and symptoms of decompression sickness that's not well understood. The fatigue that should get your attention is the fatigue that is out of proportion for the amount or type of diving you were doing. Those of you that have a good experience base, you know how tired you should be by the end of the day. If it's more than you would expect, be suspicious. Or if it's the type of fatigue that does not get better with rest, that should raise the index of suspicion and prompt you to start looking for other potential problems. The mental status changes, whether they're focused, whether they're having problems thinking, that can be very obvious or very subtle. So it's important to do a good evaluation on that. They can be confused. They can have personality changes. Certainly the most obvious changes are having trouble speaking or they're not making any sense when they are speaking. So these things can all come into play. And it's important to evaluate them for these signs and symptoms. If you look in the upper right corner, you'll see a picture. This was a diver that presented to Duke Hospital. He came in seeming absolutely fine, could answer questions appropriately, but they asked him to draw a clock. And you can see the rendering they came up with. I promise you that my 3-year-old granddaughter could do a much better rendering of a clock than that. But that tells you that there's something seriously wrong. He could not process the information. In the medical term, you could say his eggs were scrambled. But this is what's important to look for. Out in the field, it's not really convenient to have somebody draw a clock. What's usually recommended is that you have them count backwards from 100 by 7. I know that's a bit of a pain, but it's a good way to find out if things are actually functioning normally or not. At DAN, and I'm not trying to sell you our course, but our neurological assessment, this is a course that we redid a little over a year ago. We knew we had to. If you notice on the slates, the very information, that pertinent information that we were asking for is on these slates. It's presented in a very orderly, logical way to do it. And by the way, you'll notice that the answers to serial 7s are on there so you don't have to guess about it. These are a nice tool to have because it gives you a good way of gathering all that pertinent information and kind of walks you through how to evaluate somebody, especially that cognitive function. It really looks for those subtle signs and symptoms that aren't always obvious. So this is a good tool, and there are other similar products out there that do the same thing. Let's take a look at another case study. This is a gentleman, 37 years old, gave us a call, did 5 dives the day before, all on air. Each dive was to 80 feet of seawater. Bottom time on all dives was 30 minutes, and he would have a surface interval of 45 to 60 minutes. That's a fairly aggressive profile. Also, he was installing mooring buoys, so we know he was probably working hard at depth. When he would come up on a surface interval, he would hook his arm on the side of the Zodiac, so he would hook it over the gunnel. The next day, he's complaining of soreness in his left bicep, and he was right-hand dominant, so he was using his right hand more than his left. His left bicep was noticeably more swollen. The erythemic means red, and it was warm. As a matter of fact, his wife took a tape measure, and his left biceps was 2 inches greater in circumference than the right. So it was truly measurably swollen. So he's contacting us because naturally he's going to be quite concerned. So we, of course, referred him to local emergency department. Now, the doctor that was attending that day got his dive history. He had no previous issues with that arm, nothing that would suggest that this was connected in any way to his previous history. The doctor did not order any lab tests or imaging studies. The doctor's working diagnosis was decompression sickness. Would you all agree that that was the right thing to do at that moment? Certainly be suspicious, but the fact that nothing else was done is kind of problematic. Now, the doctor arranged for this gentleman to be transferred to a hyperbaric facility, the chamber, which was about an hour away by ambulance. Now, the only reason I mention that is 2 things. One, if the doctor had contacted Dan, we would have encouraged more diagnostics to rule out other possible causes. Also, we could have referred them to a chamber that was only 15 minutes away instead of an hour. So when he got to the chamber, the hyperbaric doctor took a look at it, did not see anything that indicated decompression sickness. But the doctor continued the diagnostic process. They got a simple X-ray of his arm, which showed that there was fluid collected in there. They also took some lab counts, and they found out that the CBC, which is a complete blood count, indicated that he had an elevated amount of white blood cells. Now, a raised white cell count can indicate an infection process. So what they found was that he actually had cellulitis, which is an infection of the skin and the tissues, and possibly an abscess. So this had nothing to do with decompression sickness. So he was treated with intravenous antibiotics and then given pills to finish the course of the antibiotics. He recovered absolutely fine. Had the initial physician not based it solely on the fact that he'd been diving and ruled out other things, he could have been treated right where he was in the first place. Let's take a look at another case. Young gentleman who was an intermediate diver, single shore dive, 97 feet for 35 minutes on air. Okay, that's a reasonable profile, certainly not without some possibility of risk. Right after the dive, he said, "I don't feel right." No other specific complaints, he just didn't feel good. 4 to 5 hours later, he complained of feeling off balance. And like we men do with our walk it off mentality, he decided to sleep for the night and reassess how he felt in the morning. Well, next morning, nothing had changed. So he gave Dan a call and we went through the history with him. Denied any past medical history or any medications. So young man had no known health history, was not taking any medications. We also asked if he had had any trouble with equalization. Balance problems can be very related sometimes to ear issues, but he denied having any problems. He did describe that he was walking as though he felt intoxicated. He was a little off balance, but he denied any other symptoms. So we referred him to the closest hospital, which did have a chamber in this case. When he got there, they found that he was indeed not walking properly and was having balance problems. They went ahead, they examined his ears. Ears were completely normal. Again, no history of any equalization difficulty. They did find that his coordination was off. They had him touch his finger to his nose and then somebody else's finger, and he could not do that correctly. It was abnormal. That indicates some serious cognitive problems. So a diagnosis of type 2 decompression sickness was made. He was treated with the 5-hour U.S. Navy treatment table 6. He still had some slight symptoms the next morning. They went ahead and treated him with the shorter 2.5-hour treatment table 5. Got completely better, no problems after that at all. So the diagnostic process in that case worked to prove that it was decompression sickness. Let's look at another case. This is a gentleman, 57. He went with 2 buddies. They were on a boat dive. His first dive was 80 feet for 30 minutes, not a particularly provocative dive. It was totally uneventful. No rapid ascents, no exertion. Everything was nice and relaxed. And they got back to the boat without any problems. 5 minutes after he was back on the boat, he lost consciousness. He still had a pulse, still breathing on his own. His buddies immediately and wisely contacted EMS by cell phone. They unfortunately didn't have any emergency oxygen on board, and it was a 15-minute ride back to the boat dock. EMS was able to meet him there and transported the diver to the closest hospital. After a very efficient and quick evaluation, the treating doctor ordered a head CAT scan. About this time, the buddies arrived, found out he was going for a head CAT scan instead of going to a chamber, and they called Dan because they were a little concerned and distressed. They were convinced that this was an AGE and he needed to immediately go to the chamber. Now, being suspicious of an AGE, we absolutely agree with them. That was certainly a possibility. They wanted Dan to correct the treating doctor and tell him that he had to get him to the chamber. We, of course, explained that it was prudent to get that head CT because even though there was a high index of suspicion for an AGE, you still had to prove what it wasn't. And in later conversations with this particular doctor, the doctor admitted he too was suspicious of an AGE, but he still wanted to make sure that it wasn't something else. Buddies were still upset and convinced the care was inappropriate. Now, the CT was completed and the doctor had the results right away, and this is what he found. It was not a decompression injury or an AGE. He had a ruptured blood vessel deep within his brain. It was what they call an aneurysm. This is a weak spot in an artery that can perforate. The diving probably had nothing to do with it. This is something that could have occurred just as easily if he was raking the yard or mowing the lawn. So this is, for lack of a better term, it does tend to act like a time bomb. So this is what was going on. The CT results showed that, and it probably again had nothing to do with the diving. He was taken immediately to surgery and they were able to repair the blood vessel. The swelling of the brain, which is edema, decreased over the next couple of weeks. He still had neurological deficits. He was discharged to a rehabilitation facility, spent 3 months there, got better, was improving, and they were able to send him home after that 3 months. After being home for 6 weeks, he completely recovered and was back to his baseline. So this could have had a very different outcome had this doctor not continued that diagnostic process, because chamber treatment for this type of injury is not appropriate. What you need to do in the field, all of us need to do, is evaluate the diver within our level of training. So whatever your level of training is, that's what you want to follow. And remember that any signs and symptoms, regardless of the cause, can worsen without intervention. If you're trained to do so, oxygen is available, certainly administer that right away. Make sure you document your findings. What were the initial signs and symptoms, and how did it react to oxygen? You can't use the response to oxygen to completely rule in or rule out decompression sickness, but whether they stayed the same, got better, or got worse is very important information to provide to the next caregiver, be it the doctor or EMS. Please pass that information along, because that will ultimately help the doctor make that diagnosis. Remember that decompression illness is a probabilistic event. It's just a matter of occurrence. You almost never know exactly when it's going to happen. That thorough evaluation is critical because you have to be sure of what you're treating. And please trust that diagnostic process. It is being done for good reason. And remember that treatment is based on the diagnosis, not the events. Not all symptoms after diving indicate a dive injury. And even at that, not all dive injuries require treatment in a chamber. Sinus, ear, or pulmonary barotrauma, that does not get treated in the chamber. Dan is always available for consultation. We're on that emergency line 24/7. We spend a great deal of time speaking with emergency room physicians and help them in that diagnostic process and getting the diver to where they need to be for appropriate treatment. So remember, encourage that kind of communication. So please remember that to trust that diagnostic process, make sure that an injured diver gets to the closest hospital, and then we're available to work with you. And I thank you all for your time and attention.